Recording accurate neurological observations is a vital part of the nursing care required by many patients. Relatively small changes in a patient's conscious level can give an early warning of a potentially serious deterioration in their general condition. These observations, however, if not performed in a reliable manner, can be misleading and lead to a delay in appropriate action being taken. This video will detail why and how to undertake and document a basic nursing assessment of a patient's neurological state. In order to do this, several areas will be considered. Firstly, unconsciousness. What is it? What causes it? And why should we assess conscious level? And secondly, neurological assessment. What are its components, and how and when should it be carried out? Unconsciousness can be defined as the absence of general awareness of oneself and the surrounding environment. This loss of consciousness may result from a variety of causes such as cerebral trauma, hemorrhage or infarction, infections like meningitis, toxins, for example alcohol or drugs, or metabolic causes like hyperglycemia or renal failure. With any case of decreased conscious level, assessment is vitally important. It allows the detection of life-threatening situations, the establishment of a baseline upon which care planning can be based, the identification of communication difficulties resulting from neurological status changes, and the comparison of current assessments with the original baseline in order to establish if any changes are occurring, which may require alterations to be made to planned care. The frequency with which neurological assessment should be undertaken will depend on a variety of factors, but in the seriously ill patient, it may be necessary to undertake these observations several times in each hour. For example, in a patient with an acute head injury, the National Institute of Clinical Excellence recommends that neurological observations are carried out every half hour for the first 2 hours after admission, then hourly for the following 4 hours if the patient's condition remains stable, and every 4 hours thereafter until neurological observations are discontinued. If at any time the individual's neurological status deteriorates, however, then the frequency of observations should be increased again. There are 4 components within a standard set of neurological observations, as shown on this chart. Firstly, the vital signs, then the Glasgow Coma Scale, the pupil size and response, and lastly, limb movement. These components and how they are assessed will be discussed in turn in the following sections of this video. As the brain contains the centres which control temperature, pulse, blood pressure and respiration, as well as being responsible for consciousness, anything which causes a decrease in the conscious level may also have an effect on these vital signs. In addition to this, the patients with decreased conscious level may not be able to maintain their airway safely, so an assessment of vital signs, including airway patency, should always be the initial component of neurological assessment. Here we see the vital signs of a patient who has suffered from an intracranial hemorrhage, which is increasing in size over time. As the pressure within their skull, due to the increasing size of the blood clot within their brain, increases, note how their pulse rate and respiratory rate drop, and their blood pressure rises. In addition to this, the increase of pressure within this individual's skull would usually lead to severe headache and vomiting, as well as a decrease in conscious level. The next component of neurological assessment which should be undertaken is the patient's Glasgow Coma Score. This consists of 3 separate components: eye opening, verbal response, and motor response. The patient's best responses in each of these categories should be charted, with a minimum score for each category being 1 and a maximum score of 4 for eye opening and 5 for verbal response. Some areas, however, use a 6-point scale to assess motor response, allowing movements known as abnormal flexion to be differentiated during assessment. This is not the most commonly seen method of motor function assessment, however, so for the purposes of this video, the assessment chart recommended by the Scottish Intercollegiate Guidelines Network, or SIGN, which is shown here, will be used, with the maximum score for movement being 5. The following section of this video will demonstrate the various responses which may be seen when a patient's Glasgow Coma score is being assessed. This patient is opening their eyes spontaneously and therefore scores a 4 for eye opening.
Hello, John.
This patient only scores 3, as they required stimulation in the form of speech from the nurse in order to open their eyes. In order to assess patients who do not respond to lesser stimuli, painful stimuli must be applied. When assessing a patient's response to painful stimuli using the Glasgow Coma scale, a central painful stimulus is required. This is because painful peripheral stimuli may result in responses which are merely spinal reflexes. So, there are 3 potential methods of applying a central painful stimulus to a patient, and the area chosen should avoid any areas where the patient is known to have fractures or injuries. Firstly, the trapezius squeeze is performed by using the thumb and 2 forefingers to squeeze and twist the trapezius muscle, as shown here. Secondly, supraorbital pressure can be applied if the trapezius squeeze is inappropriate due to shoulder or neck injuries. It is applied by pressing on the notch in the bony ridge above the eye, as shown here. This method should not be used for patients with facial fractures. And thirdly, jaw margin pressure is another method which could be used and is applied by pressing just in front of the earlobe, as demonstrated here. Again, this method should be avoided in patients with facial injuries or if a basal skull fracture is suspected.
Hello, John. It's the nurse here. Can you open your eyes at all? Okay, John, what I'm going to have to do just now, I'm just going to pinch your shoulder here. It'll be a wee bit uncomfortable. Sorry about this.
This patient only opens their eyes when the nurse squeezes their trapezius, so they score 2.
Hello, John. John, I'm going to have to just pinch you to the side of your neck here. It's a bit uncomfortable. I'm sorry about this.
As this patient does not open their eyes even when a painful stimulus is applied, they score the minimum possible score for eye opening, and that is 1. The next aspect of the patient's assessment is their verbal response. As this involves establishing whether a patient is orientated, the nurse may already be aware of the patient's score, having communicated with them while undertaking the first part of the neurological assessment.
Hi, John.
Hiya.
Would you be able to tell me where you are just now?
I think I'm in Glasgow Royal.
Yep, that's right. And can you tell me what day of the week it is?
It's Thursday today.
That's right, yep. And do you know how you ended up in here?
I was just really brought in by an ambulance. I had a fall of some kind. I'm not really sure about all the
Yeah.
details, but
You've had a
came in
bit of
from
a
an
bang
ambulance.
to your head, yeah.
Ah, right.
As this patient appears to be orientated, their verbal response score is 5.
Hello, John. Can you help me out with some questions here? I
don't
was
know.
just wondering, do you know who I am?
No, should I?
I'm one of the nurses here. Do you know where you
Nurses?
are?
Where? No. How did I get here?
You're in the hospital, John.
A hospital?
Yes, you've had a bang on your head.
When?
Okay, you had a bang on your head this afternoon. Okay, it's Thursday
I'm supposed to be
afternoon.
at work.
No, John, you haven't been working for a few years.
What?
As this patient's conversation is clearly confused, then they would score 4 for verbal response.
Well, John, I'm just going to take your
what?
temperature in your ear
Hi there.
here, if that's
So,
okay.
what's it? Hey, let's get on.
Oh, you're
Yeah,
okay. You're okay,
yeah,
John. You're still
yeah.
in the
Not
hospital.
bad, yeah.
The words that this patient is using are inappropriate, and they score 3 for verbal response. Verbal outbursts such as unprovoked swearing would also be scored as a 3.
Okay, I'm just going to take your blood pressure here, Mr. Murray. You'll just feel that cuff tightening up a wee bit around your arm. And just loosening up there.
Here we again see that a patient's level of consciousness may be apparent even while other aspects of nursing care are being undertaken. The incomprehensible sounds that the patient is making mean that they would score 2 for their verbal response. Patients who do not make any sound in response to stimuli would score 1 for verbal response. And if they have an airway or a tracheal tube in place that would prevent them from being able to speak, even if they were to attempt to do so, then instead of receiving a score of 1, they would have a letter T marked in the no response section of the Glasgow Coma Scale portion of the neurological observations chart. Now you will see the potential results of an assessment of a patient's motor response using the Glasgow Coma Scale.
Okay, John, could you do a few things for me? Could you stick out your tongue for me? That's good.
The initial assessment of a patient's motor response should usually assess their ability to move their mouth or tongue unless they have injuries in this area. This is in case they have an injury to their cervical spine or the spine within their neck, or other neurological problem which could prevent them from moving their body. As this patient is able to obey commands, then they score 5. After initial assessment, or if the patient is not able to move their mouth, their ability to obey commands with their upper limbs or arms has to be assessed.
Now, can you lift your right hand and give me a thumbs up sign? Thumbs up, that's good. And can you give me a thumbs up with your left hand? That's good, yep.
Here we see the nurse using a trapezius pinch to see if the patient can localise to a painful stimulus. By localise, we mean that the patient will attempt to bring their hand up to the location of the pain. Where the pain is applied to the patient's neck, as seen here, in order for them to score 4, their hand must reach to at least the level of their collarbone. The patient here only flexes their arm in response to the painful stimulus, but does not raise it sufficiently to localise to the area of discomfort. Their score is therefore 3 for movement. Here we see the patient extending their arms in response to pain. This would score 2 as a motor response. It can be seen at this level of consciousness that patients' movements appear increasingly abnormal. Where there does not appear to be any motor response to pain, always apply a painful stimulus to both sides of the body in order to confirm that the patient definitely scores only 1 for movement. Remember, it is the patient's best score which is charted in each of the 3 areas of assessment of Glasgow Coma Score. These 3 areas are eye-opening, verbal response and motor response. Assessment of patient's pupil size and response to light is another vital part of their full neurological assessment. Particularly in unconscious patients, changes in pupil size and reactivity are sensitive indicators of neurological deterioration, as pressure changes within the skull, resulting for instance from bleeding or swelling, lead to compression of the cranial nerves which control pupil response. Before commencing pupil assessment, the overhead light should be dimmed, or the patient's eyes shielded by the nurse's hand. The patient should then be asked to open their eyes, or the nurse may carefully open an unconscious patient's eyes. Where a patient's eye cannot be opened, due to swelling for instance, a letter C should be charted in the pupil size section of the chart. For all other patients, their pupil size in millimetres should now be estimated using the scale at the side of the neurological observations chart.
Just open your eyes for me.
A torch beam should be brought in from the outer aspect of each eye in turn, and the pupil should react swiftly in response. When the beam of light is removed again, then the pupil should dilate back up to its previous size. This response of the pupils to light is called the direct light response and should be marked with a plus sign on the chart if it's present and with a minus sign if it is absent. Repeating the previous procedure, the opposite pupil should now be examined, meaning that when the light is shone into the right eye, the left eye's response should be checked. The constriction of the pupil in the opposite eye to the one which is being exposed to light is called the consensual response, and this should also be present in a neurologically intact patient. At this stage in the assessment, the nurse will now move on to a more detailed assessment of the patient's limb movements. As the Glasgow Coma Scale only charts the best motor response and only records the movements of the arms, this assessment allows a clearer picture of the patient's neurological status to be gathered.
Okay, John, can I get you to take my hands? Okay. Now, could you hold my hands? Now, push me away from you. Okay, now pull me towards you. That's good. Well done. Can you straighten your leg out for me, John? Good. Good. Okay. Now try and bend your knee for me. Bend your knee, even though I'm pulling away. That's it. Good.
A patient with severe limb weakness will not be able to resist the nurse when the nurse attempts to stop them bending or straightening their limbs.
Okay, John, can you raise your arms up above your head? Raise your arms right up. That's it. And hold them there. And can you close your eyes for me?
Mild weakness can be shown using this technique.
Okay, John, can you lift your arms up above your head for me? Right up, that's it. And close your eyes for me.
This patient is demonstrating that they have a mild weakness in their right arm, and this is shown because it drifts down while the other arm remains outstretched.
Okay, I'm just going to squeeze your finger here.
At times when patients are unable to obey commands, painful stimuli may be applied to the sides of their fingers or toes, as demonstrated, in order to assess their limb movements.
Hey, John, can you open your eyes for me? Could you raise up your arms above your head? Raise your arms right up. That's it, right up. Both arms.
At times, limbs on one side of the patient may respond differently to those on the other side. This is demonstrated in this film as the patient's left arm is in spastic flexion and they are unable to obey commands with it, whereas they are able to obey commands with their right arm. When this is charted in the limb movement section of the neurological observations, an L to represent the left side should be entered in the spastic flexion box of the arms section. and an R should be entered in the normal power box. Here again, we see a patient whose limbs respond asymmetrically. This time, their right arm is extending and their left arm is flexing. You have now seen demonstrated how to obtain accurate neurological observations from an individual. These observations consist of vital signs, Glasgow Coma score, pupil size and responsiveness, and limb movements. By using these observations, clearly documenting them and communicating their findings with the multidisciplinary team, nurses can ensure that any changes in patients' conscious levels are noted and, where necessary, appropriate action taken to respond to potentially life-threatening changes in patients' conditions.